Good morning. I'll be talking about a very important problem that we often face in the ICU, pulmonary embolism, and I'll be talking from an intensivist perspective. The presentation will cover two extreme clinical case vignettes about epidemiology, predisposing risk factors, pathophysiology, and a bit about diagnosis. Then the assessment of severity, and finally we'll focus on the treatment, anticoagulation, thrombolysis, as well as other treatments. So I'm starting with a clinical case. A 41-year-old man presents to the ER with a 3 weeks history of breathlessness. He recently completed a course of antibiotic for pneumonia. On the day of presentation, he awoke with dull pain on the right side of the back. Medical history is unremarkable. Vitals are stable. He is having a saturation of 95% on room air. Auscultation of chest is normal. The heart sounds are normal. So please focus on the issue here. 40-year-old man is having breathlessness lasting 3 weeks. Nothing else. He has taken a course of antibiotic. He's hemodynamically stable. His chest is absolutely clear, but the pain is persistent. And examination of the legs is normal. Creatinine and troponin levels are normal. X-ray chest is normal. So physician's assessment of the likelihood of pulmonary embolism is more than 15%. Now, this is very important because physician's clinical assessment regarding whether patient has pulmonary embolism or not is very important here in these kind of cases. And normally the data, published literature, data in the published literature has shown that when we think that the likelihood is, there for having PE, it is more than 15%. When we think that patient may not have a pulmonary embolism, then we say that likelihood of PE is less than 15%. This patient's the prediction score, well score was done, which was 0. So D-dimer levels were 2560 and high sensitivity troponin was normal. So repeating again for your benefit, breathlessness continuing for 3 weeks, pain in the chest, and a raised D-dimer, 2560. Now, these are the issues. Now, we very well know that D-dimer has a great negative predictive value, but then this would warrant a further CTPA to prove that patient has, or a 2D echo also. So further testing is warranted. CT is indicated. Whenever the D-dimer value is more than 1000 nanogram per mil, then generally a CTPA is indicated because that's the new gold standard. The earlier gold standard used to be pulmonary angiography. And if the patient's CT scan confirms pulmonary embolism, but on echo, the RV dimensions are normal, and we knew that his troponins were normal, so he will be classified as having low risk pulmonary embolism because the troponins were normal. So here we will start oral anticoagulants and then subsequently monitor the patient. Let's see the second case, the other extreme. A 25-year-old male with sudden onset right-sided chest pain, dyspnea, hemoptysis. Look at the symptoms: sudden onset, chest pain, dyspnea, hemoptysis. There is also a history of cavernous sinus thrombosis 6 months back. Patient was not on any anticoagulation for 1 month. His vitals show that he is tachypnic, tachycardic, and is grossly hypertensive. BP is 70/50. ECG shows sinus tachycardia with right bundle branch block. On a 2D echo, RA and RV are dilated. Pulmonary artery systolic pressure is 85 millimeter of mercury. His high sensitivity troponin is raised. His anti-pro-BNP is also raised. As we know, high sensitivity troponin represents the myocardial function, and anti-pro-BNP represents our ventricular function. So when we look at the hemodynamic instability, like this patient has hemodynamic instability, the old classification that we used to use had massive pulmonary embolism and submassive. Massive would be where patient used to be hemodynamically unstable, and submassive would be where patient was not hemodynamically unstable, but would have 2D echo findings, or the biomarkers, cardiac biomarkers would be high. But we are not using that. So we classify into low risk, intermediate risk, and high risk. So let us see, this is an acute high risk pulmonary embolism who are hemodynamically unstable. This patient can be in cardiac arrest. He can be in obstructive shock, because we know there is a physical obstruction. So pulmonary embolism is a classic example of obstructive shock. Systolic blood pressure is less than 90 millimeter mercury. With vasopressors only, we are able to achieve BP more than 90 despite the adequate filling status. And there is sign and symptom of end organ hyperperfusion, that is, organ dysfunction is appearing. Organ SOFA may be high. Altered mental status, cold clammy skin, oliguria, anuria, increased serum lactate could be there. And third category is persistent hypotension, that is, the systolic BP less than 90 millimeter, or a systolic blood pressure drop of more than 40 millimeter is lasting more than 15 minutes. And the reason is not a new onset arrhythmia, hypovolemia, or sepsis. So these were the two extreme cases that you saw. So let's learn about pulmonary embolism. As the name suggests, it occurs when embolic venous thrombi are caught within the branching lung vasculature, that is the pulmonary artery vasculature. These thrombi generally develop within the leg or pelvic veins. In near-term pregnant females, generally they arise from the pelvic vein. So whenever you have a sudden and unexplained collapse in a term pregnant patient or post-delivery, then keep a diagnosis of pulmonary embolism high. About half of all deep vein thrombi embolize to the lung. Annual incidence is high, 1,000 persons. 20% of patients who are treated for pulmonary embolism die within 90 days. Pulmonary embolism per se is not a common cause of death, because there will be generally coexistence of other serious conditions like cancer, sepsis, or illness leading to hospitalization, or patient may have undergone major surgeries like a spine surgery or long surgeries. True mortality when pulmonary embolism goes undiagnosed is less than 5%. But the problem is those who we treat and those who recover from pulmonary embolism, they generally recover with complications like bleeding due to anticoagulant treatment, recurrent venous thromboembolism, chronic thromboembolic pulmonary hypertension, and long-term psychological stress. 50% of patients who are diagnosed as pulmonary embolism and treated, they have functional and exercise limitation 1 year later. This is called post-pulmonary embolism syndrome. The health-related quality of life in these patients who recover is diminished. Let us look at the symptomatology. Common symptoms are fatigue, breathlessness, chest pain, dizziness, cough, diaphoresis, fever, and hemoptysis. There is a history of dyspnea, immobilization, recent surgery or presence of active cancer, hemoptysis, past history of venous thromboembolism, or syncope. These are all associated with increased likelihood of pulmonary embolism. Misdiagnosis is common. So other diagnoses must be excluded. Testing for pulmonary embolism should be considered if a patient does not respond to treatment for another diagnosed respiratory condition. Now I'll take a pause here to explain. In ICU, most patients are extremely critical. They would already be on vasopressors, the sicker ones. They would be intubated. They would be on ventilator. So the predictive algorithm, well score, etc., they lose their value. They are mostly for the OPD settings. So here all our patients would be, generally acute high-risk pulmonary embolism patients. So we need to exclude whether this deteriorating condition is because of pulmonary embolism or ARDS, or is it because of sepsis. So a clear-cut diagnosis is oftentimes confusing. And like I said, a severe pneumonia can also make a similar presentation. So what options are available to us? Patients who is grossly hypertensive on multiple vasopressors is unfit for CTPA. So that means we can do biomarkers, we can do a bedside echo, and we can do a compression ultrasound. So these easily available tools become the standard of investigation for us. And based on these, we will have to take an urgent call whether we anticoagulate and thrombolize, these patients are not. So please understand, you cannot wait for CTPA. In these situations, CTPA is not possible. Over a period of time, because we are diagnosing more and more cases, so you can see that the annual incidence rate globally is going high, as you can see here. But the case fatality rate is coming down because of our better understanding, early pickup, and the better early anticoagulation and thrombolysis. Now, what are the predisposing risk factors? They have been classified into strong, moderate, and weak risk factors. Strong includes fracture of lower limb, hospitalization either for heart failure or atrial fibrillation or atrial flutter within past 3 months, hip or knee replacement surgery, major trauma, MI within last 3 months, previous venous thromboembolism, and spinal cord injury. Moderate risk factors will include presence of central lines, other catheters, chemotherapy, erythropoietin stimulating agents, hormone replacement therapy, IVF patients, oral contraceptives, etc., etc. And weak risk factors would be diabetes, hypertension, increasing age, laparoscopic surgery, obesity, varicose veins, etc. Let us look at the impact of obstruction of pulmonary vasculature with these thrombi. So we have occlusion of the pulmonary artery. As a result, there is pulmonary AV shunting, which results in hypoxia, which will further cause RV ischemia. And there is increased RV afterload because the pulmonary artery pressure is high. So RV has to pump against a high pressure. As a result, the RV pressure increases. As a result, the RV dilates. It also leads to neurohumeral activation. The myocardial oxygen demand is increased because of the decreasing, because of RV ischemia. And eventually, the RV contractility goes down. RV stroke volume goes down. As a result, the LV preload is also reduced, and resulting in reduction in the cardiac output and systolic blood pressure. And this creates a vicious cycle because then the coronary perfusion is reduced, oxygen delivery is reduced. So this is a vicious cycle. And of course, TR is increased, as we will see in the echo studies. So increased RV afterload in this obstructive shock can finally cause death if we do not arrest this process here. So this is very, very important. So eventually there is biventricular failure and there is ischemia of both the ventricles, and the patient goes into obstructive shock and dies. So how do we look at these predisposing factors? Well, they are mostly for, like I said, OPD patients or ward patients. So Wells is the oldest criteria. It looks at symptoms or signs of DVT, then a pulmonary embolism as the likely diagnosis as per the consultant, and history of previous pulmonary embolism or DVT. Patient has a heart rate of more than 100, has been immobilized for surgery or undergone surgery in past 4 weeks, has hemoptysis or cancer. Now, if you look at the evaluation of the score, now the modified Wells score says that if the score is less than 4 points, then pulmonary embolism is not likely. There is only 8% absolute risk. And if it is more than 5 points, then pulmonary embolism is likely, 34% absolute risk. So you can, with the conventional original score, more than 7 points give high probability, more than 50% absolute risk, 2 to 6 is intermediate, and 0 to 1 is low probability. The other score is revised Geneva score, which looks at age, then a lot of similar factors, but it looks at unilateral leg pain, and it also looks at, in addition, pain on palpation of lower limb with unilateral edema. And the points are given. And the evaluation is, if the score is less than 4, then the probability is low. Absolute risk is 9% only. If it is more than 10, then there is high probability of pulmonary embolism, 76% absolute risk. Now, this cartoon illustrates how we should go about the decision tree in the OPD setting for pulmonary embolism. So clinician feels that the likelihood of pulmonary embolism is more than 15%. He feels patient may have pulmonary embolism. He feels patient is unlikely. That means estimated likelihood is less than 15%. So let us see when it is unlikely to be as per the physician. Then whether PERC criteria are present or they are negative. What are the PERC criteria? You can see here. Is the patient more than 50 years of age? Is he tachycardic? Is his oxygen saturation less than 95% on room air? Is there swelling in one leg? Or does he have hemoptysis or recent surgery or trauma in past 4 weeks, or previous DVT or pulmonary embolism? Or is he a hormone user? If none of these is present, say PERC is negative, then straight away you can rule out pulmonary embolism. If PERC is positive, one of these or two or one or more are positive, then we need to look at the other scores, Wells score, Geneva score, revised Geneva score, and also look at the D-dimer values. Now, another criteria that is given is years, YEARS. Now, years criteria are pulmonary embolism is most likely diagnosis, hemoptysis, and clinical signs of DVT, which are redness, edema, swelling, and pain. So, supposing the Wells score is less than 4, revised Geneva score, simplified Geneva score is less than 4, and D-dimer is normal, then pulmonary embolism is ruled out. In case these criteria are absent, the years criteria are absent, and D-dimer is less than 1000 nanogram per mil, then also pulmonary embolism is ruled out. Even if one of these years criteria is present, but D-dimer is less than 500, then also pulmonary embolism is ruled out. So now let us see where clinician feels that the likelihood of pulmonary embolism is there. It's more than equal to 15%. Now, again, we have a high Wells score or a high Geneva score, and we have high D-dimer, then that warrants a CT angio, as we saw in the previous second case, or a ventilation perfusion SPECT. Ventilation perfusion SPECT is done in the nuclear medicine department, and the radiation exposure is low. But the problem is it has not been validated for quantifying the pulmonary embolism. So if it is positive, then our pulmonary embolism is diagnosed. If it is negative, pulmonary embolism is ruled out. So regarding the diagnosis, the most common thing available to us is ECG. Please understand, the most common ECG finding may just be sinus tachycardia. So the classical triad of S1, Q3, T3 that we see would be much later appearance, and possibly indicate that we are late in diagnosing and treating. Generally seen when patients are not diagnosed and shifted to a better center, and it's fairly advanced, then you see these signature marks. Now, this is an important slide because this highlights on the echo findings. Now, here you will see this is a parasternal long axis view. RV dilation enlarged, RV, the cavity size is increased. And here you can see the McConnell sign. That means there is a RV wall motion abnormality, but that excludes the apex of the RV. And third thing that you see, again, this is a parasternal short axis view, flattening of the septum. As you can see, normally septum is concave into the RV cavity, but here it is, as you can see, flattening. And also you can see the IVC is dilated and there is minimal respiratory collapsibility. This is a subcostal view. And then you can have 60 by 60 sign. That means the pulmonary ejection time is accelerated. It is less than 60 seconds. And there is peak systolic gradient at the tricuspid valve is mildly elevated. This is less than 60 millimeter mercury. Another thing that you can see is the RV embolus. Here you can see this. RV embolus could be, a thrombus, a mobile thrombus can be seen. This is between RA and RV, as you can see. And then you can measure the TAPC. TAPC we know is more than 1.7 is normal, but here you find that this will be less than 16 millimeter or 1.6. And also if you are doing Doppler in the same view, that you will find that the peak systolic velocity of tricuspid annulus is decreased, less than 9.5. So these provide valuable information in patients who cannot be shifted, who are grossly unstable. But the limitation would come in patients where the echo window is very poor, those who are very obese. So there could be issues in those patients. Now, some of the classical signs that you must have found in your books. Westermarck sign on X-ray. This is the focal oligemia that you find here. So this indicates that that particular part of the pulmonary vasculature is affected. And then you can have a Hampton's hump. Hampton's hump is peripheral wedge-shaped density that you find above the diaphragm. Or you can have Pala's sign, which is enlarged right descending pulmonary artery. These signs would be mostly just for curiosity's sake. They may be, your examiner may ask them. Otherwise, it is rare to see these signs, and the X-ray may look remarkably normal or unremarkable. And when you look at these, the importance of these signs, now look at the sensitivity, specificity. In addition, you can also get pleural effusion or elevation of the diaphragm in pulmonary embolism X-ray. But the sensitivity is very low, as you can see. The specificity is also not great. Positive predictive value is poor. Negative predictive value is also to the tune of 76% only. So that's about these so-called tests. And the next important investigation is the CTPA. Now, in CTPA, this is a normal, vascular tree, a pulmonary vascular tree. So you can see that the vessels are supplying all the lung fields in both the lungs. And when you look at the lateral view, you can see again that they are supplying there. And if you are very curious to know the anatomical distribution, you can use this chart. So here you can see how the right and left pulmonary vasculature is getting divided and further divided. So what we get here is, now here you have a saddle thrombus sitting here. This is the main pulmonary. This is right and left, and then complete occlusion, cutoff sign you can see on both the sides. There is complete peripheral oligemia. You don't see anything here. Similarly, another one where you see that there is a big obstruction here. Obstructive patient could be in obstructive shock. And again, you don't see anything. Completely oligemic fields. No vascular trees seen here. So CTPA is a gold standard. But with the modern techniques now, with the rule out criteria, with the prediction scores, and with the advanced 2D echo, the CTPA is being reserved for patients where P cannot be ruled out based on a decision tree. It is generally the most common, easily accessible technique, but where we want to minimize the lung and breast tissue exposure in younger patients, ventilation, perfusion, single photon emission, CT SPECT could be chosen as a low radiation option. Incidence of false positive results from CT screening could still be there because of the inter-observer variation. They could be as high as 5%. And literature reports that in cases where CT scan was reported as normal and CT was performed because there was suspicion of pulmonary embolism, after 3 months, about 1.2% of patients had a diagnosis of venous thrombosis. Like I said earlier, diagnostic performance of ventilation perfusion SPECT has not been well established. So here you can see CTPA when we have patients with low or intermediate clinical probability or who is unlikely to have pulmonary embolism. So if the decision tree warrants that we need to go for CTPA to reject the diagnosis of pulmonary embolism or to accept the diagnosis of pulmonary embolism, CT shows segmental or more proximal filling defect in patients with high or intermediate clinical probability, or to see the extent, etc. So, but CT venography is not recommended in addition or as an adjunct to CTPA. Similarly, VQ scintigraphy. So these are the strengths and weaknesses of different tests that you can see that SPECT produces the lowest, VQ scan and SPECT produces the lowest radiation. Lower limb compression ultrasound can also be done. And but it's important that it should, so you can see the compression test. The vein is completely collapsing in the groin, and if there is a thrombus, then the vein will not collapse. So, but the proximal DVT is of importance, not the distal DVT. So if proximal DVT is found in the compression ultrasound, then the assessment of PE severity should be considered to look at the further management. Testing for pulmonary embolism. In the US, of 20 patients who they are testing, only one comes out positive for pulmonary embolism in the ER. It's very important that physicians realize that the pulmonary embolism as an entity exists. So physician norms and local hospital culture are major drivers in decision to test for pulmonary embolism. Over the last decade or so, 1.5 decades, the scene has changed. Now the orthopedicians are very, very sensitive to the development of DVT and pulmonary embolism. So that is why you have seen that the case fatality rate is going down and the pickup rate is going up. Non-invasive tests, like I said, 2D echo is very good. Compression ultrasound can also be done. So, and these tests have reduced the use of CTPA. Only when the decision tree demands it, then CTPA is to be done. So 30 to 40% of patients with suspected pulmonary embolism only undergo diagnostic CTPA. D-dimer, again, D-dimer values in plasma are increased because of the presence of acute thrombosis due to activation of coagulation and fibrinolytic pathways. Negative predictive value is high as 95-96%, and a normal D-dimer level renders acute pulmonary embolism or DVT unlikely. Now, it is very, very important that this is valid in patients who have a low probability of DVT. So their D-dimer has the negative predictive value is ruled out. Further testing is not required. Positive predictive values are low and cannot be used as a confirmation for diagnosis of pulmonary embolism. A recently published study, however, that was a single center study, has shown a high positive predictive value also. D-dimer is elevated in many inflammatory conditions. In COVID, we saw D-dimer levels were high. Patients with cancer, patients who have undergone surgery, patients who are pregnant, severe infective or inflammatory disease. So that is another problem in the intensive care setting, where the cause of rise of D-dimer may be because of many other factors. So it loses its value. So I think in bed-bound patients who are unshiftable, 2D echo plays a major role in our units and the clinician suspicion. The specificity in suspected pulmonary embolism decreases with age. So this is also something that we have to remember. So patients who are 80 years of age, it becomes much less sensitive. Like I said, the negative predictive value is more than 95%. Now, here, this slide we have already covered. So we talk about the other biomarkers. High sensitivity troponins. Now, if the troponins are increased on admission, when you are making a diagnosis of pulmonary embolism, it indicates a worse prognosis. About 60% of the patients will have a high sensitivity troponin. If you are using this value alone, it has a low specificity and low positive predictive value. So this has to be used in conjunction with 2D echo and NT-proBNP and other clinical features. High sensitivity troponin T concentrations less than 14 picogram per mil have a negative predictive value of 98% for excluding adverse in-hospital outcome. Another new thing is hard type fatty acid binding protein, HFABP, which is an early and sensitive markers, and levels in excess of 6 nanogram per mil are associated with adverse short-term outcome in these patients. Biomarkers of RV dysfunction. We know that whenever the RV size increases, RV dilates, RV is overloaded, that increases the myocardial stretch, causing release of beta-type natriuretic peptide and N-terminal proBNP. So the plasma levels, if they are high, they will reflect on the severity of RV dysfunction. and hemodynamic compromise in acute pulmonary embolism. So please understand, troponins, if they are high, will indicate worse prognosis, and the antipro-BNP or BNP would indicate severity of the RV dysfunction and hemodynamic compromise. Low levels will exclude an unfavorable early clinical outcome. So the sensitivity is good, negative predictive value is good. If the BNP and antipro-BNP are normal, that means the unfavorable outcome is unlikely. Cutoff values for excluding unfavorable outcome is less than 500. For including that is more than 600 nanogram per mil, picogram per mil. Other biomarkers are lactate, but lactate could be there high in shock and other conditions. So this is not a specific biomarker. This has to be treated like in any intensive care unit patients, critical patients we are using, not specific to pulmonary embolism. Serum creatinine, so the patient may go into AKI because of shock. So serum creatinine may be increased. It is important because we need to modify the doses, not only of antibiotics and other drugs, but also of the anticoagulants. Copatin is another surrogate marker because when patients is in shock, then vasopressin is released. So this copatin, which is a surrogate marker for vasopressin, can be measured, and levels in excess of 24 picomole per liter are associated with 5-fold increased risk of adverse outcome. Now, next important issue is looking at severity of pulmonary embolism. So people have given us a score, pulmonary embolism severity index, PESI. Now here you can see the components of PESI. So males have a high risk, cancer, CHF, COPD, tachycardia, hypotension, tachypnea, hypothermia, altered mental status, decreased saturation. So all these are there. And then there are two ways you can interpret it. You can either follow this regime, that 0 points, which suggests that 30-day mortality risk is only 1%, or more than equal to 1 point, which indicates that the risk has increased to 10.9%. Or you can have classical class 1 to class 5, where class 3 to 5 indicate moderate to very high mortality. So if the patient has class 1 and class 2, that indicates low mortality risk. So this is something that you need to remember. Prognostic severity assessment strategies. Now, this is important for you to understand. Like I said, now we talk about high mortality risk, pulmonary embolism, intermediate and low. Intermediate is divided into intermediate high and intermediate low. Now, for being classified as associated with high mortality risk, the patient is hemodynamically unstable, and the PESI classification, the pulmonary embolism severity index, belongs to class 3 and 5. Or if you are looking at simplified PESI, it is more than equal to 1. Echo shows RV dysfunction, CTPA shows a filling defect, and the cardiac troponins are increased. When you look at the intermediate levels, now hemodynamically patient is stable, but PESI severity index is high. It's on simplified more than equal to 1 and or class 3 to 5. And RV dysfunction and elevated cardiac enzymes are present. If both are present, we call it intermediate high. If one of these is present, we call it intermediate low. In low, every patient is hemodynamically stable. The severity is very low. Echo is normal. CTPA is normal. So cardiac enzymes are also normal. So when we have, next question that comes to mind is, when we have a suspected pulmonary embolism in patient with hemodynamic instability, what should we do? Well, go for bedside transthoracic echo. Look for the RV dysfunction. If it is present, you need to go for CTPA. But is it feasible? Is it immediately available? If it is available, yes, go for CTPA. If it is positive, then start treating. High-risk pulmonary embolism has been identified. If it is not available, then look at the algorithm. You have confirmed from this no, it is not available, or patient is far too sick to be shifted, start treating for high-risk pulmonary embolism. So do not fight with other units or consultants that I will not thrombolize or start anticoagulation without a CTPA. If RV dysfunction is not there, then search for other causes for shock or instability. So here, this diagnostic algorithm is basically telling us which patients will require immediate reperfusion. And patients who are having suspected pulmonary embolism, but there is no hemodynamic instability, again, we have to assess clinical probability. We can use our clinical acumen, less than 15%, more than 15%, what we discussed, or we can follow the prediction rules. If the clinical probability is high, that is more than equal to 15%, or pulmonary embolism is likely, based on our scoring systems, then we go for CTPA. If the PE is confirmed, start treating them. If CTPA is negative, no treatment, or we need to investigate further. But if the probability is, clinical judgment is less than equal to 15%, or the scores are low, that means low or intermediate clinical probability, or PE unlikely, then we go for D-dimer test. So here is the role of D-dimer. If D-dimer is negative, that rules out, no treatment is required. It has ruled out pulmonary embolism. However, when the D-dimer comes positive, then again we have to go for CTPA. And if CTPA confirms the filling defect, then pulmonary embolism is confirmed. Patient should be treated. If CTPA is normal, then obviously it is not a case of PE and no further treatment is required. Look for other issues. And this is another treatment algorithm now for patients with acute pulmonary embolism. All patients need to be anticoagulated initially. The most common drug that we use is low molecular weight heparins, or unfractionated heparins, or fondaparinux. If patient, after this is the first step, then if the patient is hemodynamically unstable, reperfusion treatment, generally thrombolysis. Okay. If he is not hemodynamically unstable, then we have to see whether it is low risk or intermediate high risk. So that will depend on the PASI classification. It will depend on the echo. So if we find that the clinical signs of severity are not there, PASI class is 1 or 2, then RV dysfunction is not there, then obviously there is no reason for hospitalization. And no reason for hospitalization. And if there is a family who can provide support and there is easy access to medical care, discharge the patient on home treatment. However, if that is not true, so then you will obviously have to keep the patient in the hospital. But in case the PASI class is high, or Hestia criteria, we'll talk about that, more than one criteria for pulmonary embolism severity. These are severity criteria are present, then troponin test should be performed. If troponin is positive, then, and there is presence of RV dysfunction, this is intermediate high risk case where we have already done anticoagulation. We need to monitor, and whenever the situation demands, we need to go for rescue reperfusion. If they are troponin negative, they are intermediate low risk, they need to be hospitalized and monitored. Treatment in acute phase. Well, these patients, obviously, those who are in shock will be in right ventricular failure. So your POCUS will play a very important role, because these patients, some of these patients may be fluid depleted. So, but a little fluid overload can worsen the situation. So if fluid is required, give in lower volumes, slowly, say less than 500 over 15 to 30 minutes under ultrasound guidance, so that you can avoid volume loading. Vasopressors and inotropes, norepinephrine can be given. It increases RV inotropy, systemic blood pressure. High doses may cause vasoconstriction and worsen the tissue perfusion. Dobutamine can be started as it increases RV inotropy, lowers the filling pressures. But please understand, do not start dobutamine in a patient who is still in shock. So once you have restored the pressure after volume resuscitation with norepinephrine, then only you should start dobutamine. Or some patients who have arrested or who are extremely sick, Unresponsive may require mechanical circulatory support in the form of VA ECMO. Now, high-risk pulmonary embolism, circulatory collapse, or cardiac arrest are usually the patients who may undergo VA ECMO. But VA ECMO as a standalone technique with anticoagulation still remains controversial in pulmonary embolism. Please understand, if your patient where you have a strong suspicion of high-risk pulmonary embolism sustains cardiac arrest, still go ahead and give thrombolytic therapy. And once you have administered the thrombolytic drug, CPR should be continued for at least 60 to 90 minutes before terminating resuscitation attempts. So this is a very important point. Initial anticoagulation, like I said, subcutaneous weight-adjusted low molecular weight heparin or fondaparinux or IV unfractionated heparin. In situations generally where you are, there is a kidney issue or AKI and you are going straight away for thrombolysis generally or any other procedure, then unfractionated heparin is generally used. So, but otherwise, LMWH and fondaparinux are preferred because there is a low risk of induced major bleeding and hit, and we do not need to monitor the anti-10A levels. If LMWH is prescribed, adjust the dose as per the creatinine clearance. And if creatinine clearance is less than 30, generally, or patient is severely obese, unfractionated heparin is recommended. The NOACs or DOACs, the oral anticoagulants, non-vitamin K oral anticoagulants, they have been shown to be as efficacious as other LMWH or other therapies. So they can be used, apixaban, rivaroxaban, these can be used. When we are using vitamin K antagonists, like if warfarin is being used, then anticoagulation with unfractionated heparin, LMWH or Fonda should continue in parallel for at least 5-6 days until INR has come to a level between 2 and 3 and remain so for 2 consecutive days. Then you can put them on the vitamin K antagonist alone. Reperfusion treatment, like I said, we do thrombolysis. So the drugs most commonly used are RTPA and urokinase. RTPA 100 milligram given over 2 hours, 0.6 milligram per kg over 15 minutes. Maximum dose is 50 milligram. And urokinase is 4400 IU per kg as loading dose over 10 minutes, followed by 4400 IU per kg per hour over 12 to 48 hours. So same rules should be followed. Contraindications should be found out, and if there are no absolute or relative contraindications and you feel it is safe, you should thrombolize. Other treatments are percutaneous catheter directed treatment, where through a femoral route you are inserting a catheter through the femoral vein and directing it into the pulmonary vasculature. Different type of catheters are available. So you can do mechanical fragmentation, thrombus aspiration, pharmacomechanical approach, which combines mechanical or ultrasound fragmentation of thrombus with in situ reduced dose thrombolysis. That means besides this, you can give a lesser dose of thrombolytic agent. Surgical embolectomy, I have not seen so far. Generally, patient is put on cardiac pulmonary bypass, no cross clamping is required. And incision is given on the 2 main pulmonary arteries, and you remove or suck out the fresh clots. And recent reports suggest that they are favorable, but normally percutaneous catheter directed treatment is what I have seen people doing, not the surgical embolectomy in cases. Vena cava filters, the idea is to interrupt the vena cava and prevent venous clots from reaching the pulmonary circulation. Most devices that we have, the filters that we use are inserted percutaneously. They can be retrieved after several weeks or months. Normally, in normal kind of pulmonary embolism after 3 weeks, or they can be left in place over long term if the patient continues to be a high risk for recurrent pulmonary embolism. Potential indications would be venous thromboembolism, an absolute contraindication to anticoagulation treatment, recurrent pulmonary embolism despite adequate anticoagulation, primary prophylaxis in patient with high risk of venous thromboembolism, Other potential indications include free-floating thrombi, etc. So this slide summarizes the issues with all the therapies that are available. So anticoagulation with unfractionated heparin, including weight-adjusted bolus adjustment in patients with high risk, systemic thrombolysis, surgical pulmonary embolectomy in patients with high risk where thrombolysis is contraindicated or has failed, catheter-directed only when thrombolysis is contraindicated or has failed. So ECMO may be considered in combination with surgical embolectomy or catheter-directed treatment. So that's what I meant when I said ECMO alone is not enough. So you may have to combine this with surgical embolectomy or catheter-directed treatment. So talking about suspected pulmonary embolism during pregnancy. High pretest probability or intermediate low probability, D-dimer levels are positive. We need to anticoagulate with low molecular weight heparins. We may or may not go for chest X-ray, compression proximal Doppler ultrasound if symptoms and signs are suggestive of deep venous thrombosis. Proximal DVT, if it is present, then we need to continue with the low molecular weight heparin in therapeutic doses. Look at the PE severity, risk of death, etc. Now, in all these cases, the intensivists, the cardiologists should be involved. It has to be a multidisciplinary team. If proximal DVT is not present, then we can look at the feasibility of doing these investigations to rule out pulmonary embolism. But again, a senior radiologist or nuclear physician has to review the report to exclude the diagnosis of PE in pregnancy. Duration of anticoagulation, normal pulmonary embolism, where the risk factors are reversible. The long-term risk of venous thromboembolism is low. You can remember that it is for 3 months, up to 3 months. So which includes patients who have undergone surgery with general anesthesia lasting more than 30 minutes, who have been in the confined to bed for more than 3 days, or had major trauma or fracture. Very large pulmonary embolism, where there is moderate RV dysfunction or patient has residual symptoms, we may extend this treatment to 6 months. Patients where provoking factors are persistently present, like active cancer, antiphospholipid syndrome, previous history of unprovoked venous thromboembolism, then because the recurrence is high, risk of death is high, indefinite anticoagulation therapy is recommended. So these are some of the things that you can read. This is a very good New England Journal article. Now, there are few areas of uncertainty. One of them is subsegmental pulmonary embolism. Subsegmental means a single isolated subsegmental pulmonary embolus, or they could be multiple emboli, without the presence of pulmonary embolism in either segmental or more proximal pulmonary vessels, and there is no DVT in the legs. So what should be the appropriate management is uncertain, but we know surveillance alone is not enough. So without anticoagulation, surveillance is not enough. So you need to continue them with anticoagulation and then continue their surveillance to look at the recurrence of venous thromboembolism. These are the drug doses of DOACs that you can see. So when you are looking at short term, you can start with initially with a higher dose, say apixaban 10 milligram, BD for 7 days, then come down to 5 milligram BD, rivaroxaban 15 milligram twice a day for 3 weeks, and then you can come down to 12 milligram once a day. So these are the standard things that has been recommended. Or you can have initially, you can use the low molecular weight heparins for up to 5 days and then make a switch to dabigatran or other drugs. Lastly, now this is one of my last slides. Let us look at the decision tree. Pulmonary embolism has been diagnosed. This is a high-risk patient who has shock, end-organ hyperperfusion, hypertension, or cardiac arrest. The treatment is immediate reperfusion therapy. Intermediate risk, signs of right heart strain on imaging, elevated troponin, BNP, or both are there, but patient is not in shock. Admit, monitor, vital signs, and anticoagulate. Low risk pulmonary embolism, all other patients. Here, use your criteria, Hestia criteria or PESI score. If they are low, then patient is suitable for discharge, then you can discharge. If all these are not there, patient is not suitable for discharge, then you can admit on DOACs or LMWH plus vitamin K antagonist. Now, this is a Hestia score, as you can see. Again, it is an outpatient decision support algorithm for starting anticoagulant therapy in patients who are low risk. So Hestia score has patient is hemodynamically unstable. Any one could be causing a score of any Hestia criteria being present. Patient considered for reperfusion, high risk of bleeding, oxygen supplementation required, so on and so forth. PESI we already have seen. So my final remarks are pulmonary embolism is a common diagnosis and can be associated with recurrent venous thromboembolism. A minority of patients with possible pulmonary embolism benefit from chest imaging, that is computerized tomography. Initial treatment is guided by classification of pulmonary embolism as high risk, intermediate risk, or low risk. Most patients have low risk pulmonary embolism and can be managed at home with a direct oral anticoagulant. Anticoagulant therapy should be given for at least 3 months. Decision to continue anticoagulation treatment indefinitely depends on whether the associated reduction in risk of recurrent VT outweighs the risk of increased risk of bleeding. Patient should be followed longitudinally to assess for dyspnea or functional limitation, which indicate that patient may have developed post-pulmonary embolism syndrome or chronic thromboembolic pulmonary hypertension. And there are two very good references, New England Journal of Medicine, published in New England Journal of Medicine, and European Heart Journal. European Heart Journal gives us the guidelines, and New England Journal of Medicine article gives us the abridged algorithm and management of pulmonary embolism. Both are worth a read. Thank you very much for your attention.